Hello, I'm Professor Patrick McGorry. Welcome to today's webinar. Before we proceed, as Executive Director of Orygen, I would like to acknowledge the traditional custodians of the land on which we work around Australia and pay my respects to elders both past and present.
Welcome everyone to this special webinar. We have Dr. Ashok Miller visiting with us today at Orygen, and we're very lucky to have him. So Dr. Ashok Miller is Professor of Psychiatry at McGill University, where he holds a Tier 1 Canada Research Chair in Early Psychosis, and he was the founding director of the Prevention and Early Intervention Program for Psychosis in Montreal at the Douglas Mental Health University Institute. He's also the lead investigator of Access Canada, which we'll be talking about a bit more today. His clinical and research interests have been primarily related to multidisciplinary research in schizophrenia, with an emphasis on psychopathology, role of stress and neurobiological and social predictors of outcome, clinical trials and early diagnosis and case identification, community interventions to reduce delays in treatment and quality of life. So very broad and very deep research interests as well. So more recently, as I mentioned, he's led the Access Open Minds research project, focusing on developing, testing and evaluating a new evidence-informed and scalable framework of mental health care at different sites across Canada, with the intention of giving youth aged 11 to 25 years faster access to services designed specifically for them and with them. So welcome and thank you for coming.
Thank you. Thank you for having me.
So I'd like to start perhaps by asking you about how the Access Open Minds project came about.
Yeah, I think there's a little bit of a history to this. Just like you have in Australia, you have the MRC, I presume, we have the Canadian Institutes of Health Research. And a number of years ago, the federal government decided that the research, that the healthcare research that was being conducted wasn't really benefiting patients directly. It was a bit removed. So they decided to create a new initiative called Strategies for Patient-Oriented Research. And the Strategies for Patient-Oriented Research is managed by the Canadian Institutes of Health Research, but it's funded separately. And the focus there is that not to produce new pure research evidence, but to apply the evidence that is, but produce evidence in terms of how you implement evidence into service in real kind of world settings. So it's mostly kind of an effectiveness type of studies, and also to create it as networks, so it actually is across the country as much as possible. Mm-hmm. So the first SPORE, as it is called, Strategies for Patient-Oriented Research, the first initiative was in mental health, which was quite a surprise. And the way these things are funded, the government puts 12.5 million, and in this case, one of the philanthropic foundations that is dedicated entirely to mental health and now entirely to youth mental health, the Graham Beck Foundation, they provided an equal amount, and so there's a $25 million project. Now there are several other networks that have been launched, mostly in chronic diseases, non-communicable chronic diseases. So, and after it was set up, then there was it was called Transformational Research in Adolescent and Youth Mental Health, and the competition was opened, and 54 applicants actually submitted a letter of intent, out of which 18 were kept. It was a very interesting process. The 18 that were retained were actually brought together in a room and put together for 3 days to figure out how to reduce the number of applicants and create networks.
Wow.
And it was kind of a very interesting process. It required both cooperation but also competition. And it was a bit of a kind of a bidding. And we were one of the major networks that had put in. We already were a network with 2 or 3 different programs, and we managed to attract 9 out of the 18 applicants to our, and then ultimately it ended up with 3 networks went to the final stage. There was the stage 3, and fortunately, we were successful to get the grant. So the whole process took about 18 months.
Wow.
And we finally got the grant sometime in the middle of 2014. So, and what essentially Access Open Minds is a network of several sites. So the structure of it is that obviously, as we have a number of PIs, I'm the nominated principal investigator, and the PIs are clinical service providers, researchers. Most of the researchers are actually service providers as well. But we also have PIs who are family members, who are representing families, representing youth, and also policy. The whole idea was that you have 5 stakeholders involved. That would be researchers, service providers, decision makers, policy makers, youth, and family. So that's how essentially it is. Yeah.
Fantastic. It sounds very exciting, but also incredibly complex as well.
Right. Yes, it is very complex.
Can you talk to us a bit more about the sort of the background or the rationale for this project? You know, why now in Canada?
Yeah, I think like anywhere else, whether it's Australia or Britain, you know, we have the prevalence, and especially the untreated prevalence of both mental disorders and substance abuse, as you can see here, is really relatively high. I think it hovers around 18-20% in most places. So, and about 2/3 of it, at least in Canada, is untreated. So that's rationale number one. We also have this huge problem of suicide being a leading cause of death in this age group up to 25. By the way, the Access Open Minds, or the whole TRAM process, was designed to address mental health issues, mental disorders from the age 11 to 25. So that's another. Now we have a particular, I don't know if it's the case in Australia as well, I guess it is, that we have a particularly very really alarming and in many ways I would say disgraceful sort of situation with our Indigenous people, how they have been treated culturally and in every other way, but often expressing itself in higher rates of mental disorders, addiction, and particularly suicide. And here you can see it's about 5 to 7 times the rate of suicide compared to the non-Indigenous population. And I think, as I'll show you in a few minutes, we actually, one of the peculiar things or unique things for Access Open Minds is that half of our sites, out of the 13 sites, 6 are Indigenous sites.
Oh, yeah.
So we wanted to address this particular problem head on. So those are, you know, some of the rationale. And, you know, the other rationale is that with all of that, there's very little actually that's available, very little that's easily accessible, and very little that actually is very high quality. So, and again, I don't think it's any different from what it may have been here before Headspace was started.
Absolutely. So in terms of thinking about the kind of aims of this research project, I mean, it seems like there might be quite a few, but in thinking about what you were wanting to achieve through the project, what would you say are the main kind of aims?
Yeah, let me first of all, I forgot to mention that ACCESS actually stands for Adolescent, Youth, Client-Centered, Community-Oriented, Early Stigma-Free Services. That's the whole, for the
It kind of explains the aims, though, doesn't it?
Exactly. And that's why I mentioned that it sort of explains the aims. It also explains the values. But overall, really, our objective was to develop, implement, and evaluate an evidence-informed, sustainable, scalable model for the transformation of youth mental health services. When TRAM was announced, it was made very clear We do not want projects that are going to tinker with the system.
Mm-hmm.
We want a real transformation that can actually benefit people who are going through these services. So that was, that was the main objective. But in terms of how, as I mentioned, we have multiple stakeholders, and it was a requirement. And at the same time, doing it that way, we know that it's probably going to be more sustainable, but actually doing it is not easy.
Mm.
To involve people who traditionally have not been involved, but also to convince some of our colleagues in services, in service delivery, that it is important to involve everybody. That's
And it seems like a key. I guess now in youth mental health we talk about involving young people and families as being the basis of what we should be doing. But I guess not all sectors see that as a primary kind of interest. So it would be, I guess, challenging in the sense of bringing everyone together.
Exactly, yeah. But in terms of what we were talking about, the objectives, and our overall vision was that young people in Canada who clearly are in need for services, that they get timely, high quality service, and that their outcomes are better. And we want to create a service that young people should actually want.
Mm.
So, in terms of what our overall objectives were.
So I was just wondering about, we talked about youth involvement and family involvement, and how much young people and families have been involved in designing the services that you're implementing.
That certainly from the very beginning, when we started our letter of intent, before we even created the network, we had family involvement, maybe not as much a youth involvement.
Mm-hmm.
However, once we got to stage 2, what we did at that point, it might be worth mentioning this in terms of the process. Once we got past the letter of intent, so we were in the competition, and we already had all these 9 other groups join us. What we realized is that we have a wonderful opportunity of having people who represent large urban centers, small urban centers, rural centers, and Indigenous communities.
Mm-hmm.
So it was a really, for us, this was the ideal sort of network. However, we still needed to make sure that we have real youth involvement. And I think that we managed to achieve at that stage. What we did was we had a small grant to prepare for the final application, plus we used some of our own funds and brought everybody together in Montreal from different parts of the country. And we had 3 days of sorting out what this is all about, and youth really emerged. I actually have to say I learned a lot. Youth emerged as a significant voice, and where it helped us particularly was to define our values. And give you an example of what I remember very clearly, that one of the young people said that, when I went to get service, I felt that I was made to feel that I am the problem, not that I have a problem. And she said, I said to the psychiatrist, look, I am not the problem. I have a problem. Can we work on it together? To all of us at the time, it was kind of like, Eureka, we have a real value here.
Yeah.
to incorporate and an objective for us to define. So after we got the grant, what we've done is we've created in our governance structure, we have a youth council, a national youth council, and we provide them every year an annual budget that they operate, and they get paid for the work that they do. And then at each site, we have 13 sites, it is a requirement for each site, which is basically the service hub, to have exactly the same stakeholder representation at the site level as there is at the national level. And then we also created a family council because we realized that the two have to be separate because they have very different objectives, and sometimes they have common objectives as well.
Mhm.
And again, they have a yearly funding, and they have, both the youth and the family councils have been recruiting more and more people across the country. So that's sort of, it's not been easy in the sense that, you know, some people are reluctant to get too involved. They have other lives to lead and so on. But in general, I think it has progressed well.
Mm. And it sounds like it's been such a valuable part of, you know.
Definitely. We just had our second annual network meeting, and it was quite phenomenal because it was, I had personally sort of insisted that this meeting has got to be led by the youth. They were hesitant to start, which is understandable. It's a huge responsibility.
Mm.
But we have one of our staff is pretty well dedicated to youth and family engagement, and she, you know, kind of chaperoned them, and they did a fantastic job of actually emceeing the whole network, 3 days of network meeting, and there we saw, yes, our work over the last year and a half, 2 years is really beginning to pay off in terms of youth involvement. We have a long way to go still at
Absolutely.
some sites particularly.
Yeah, absolutely. So I guess we've sort of talked through a little bit of part of the process that you've gone through in terms of implementing this project. But I guess I'm wondering whether you can give us a bit of an overview of how you've gone about it, because it seems like that's one of the critical kind of factors in ensuring the success of this is how you roll it out.
Exactly. Okay, I think maybe there's basically sort of four parts to it. The key is, first of all, how do you transform the youth services? And the model essentially that we've taken is what had worked for us for years in the early psychosis field,
Mm-hmm.
in terms of quick access, early case identification, and so on. So that was one part. The other part was that we very early on, as I said, realized that we cannot do this project several times. So we have to have representation of sites in such a way that it actually defines what Canada is, which is huge country geographically, a few very large urban centers, but a lot of Canadians live in small urban centers, and then we have the Indigenous people who live in very remote areas. So that was one of the other things in terms of process of making sure that we have that sort of representation.
Mm-hmm.
And then we also picked up one other site, which is first-year university students at one of our large universities, University of Alberta, because they're 18, 19, they've just left home. 40% of the students at that university do not belong to that city, so they've left either their rural homes, or 20% actually are international students, very vulnerable. So, you know, that was the sort of the context so that we could actually say, well, this project, this model, you have to modify it for each of these contexts, and if you do, these are the results. So we cover basically 6 provinces and 1 territory, and here you can see the map. And as you can see, way on up there at the top, that is a site, an Inuit site. It costs more to fly there than it would probably cost us to come from Montreal to Melbourne.
Oh, wow.
So it's it's very remote, but we also have several other remote communities. We have some embedded in what we call the reserves, you know, where some of the First Nations people live. And then we have 2 large cities, Montreal and Edmonton, and then some small urban in New Brunswick, and a small urban come rural center in Ontario. So what is the real transformation? We have essentially there's 5 pillars, 5 objectives. The key here is that the objectives are common to all the sites. Everybody has to meet those objectives. How each site reaches that is going to be different, because what will work in Edmonton and Montreal is not going to work in a small rural urban place. And the 5 objectives were really early case identification, rapid access, continuity of care beyond the age of 18, so no transition at 18, youth and family participation, and then connection to appropriate care. So these are the 5 objectives. Now, what's the sort of the content? Early identification. Now we have provided training to each of the sites of techniques for early case identification. But there is a good example of what would work in Montreal and Edmonton is going to make no sense at all in a small Indigenous community. In fact, in small Indigenous communities, they are much better at pulling because they're small communities, pulling the whole community together, and it's through word of mouth, and it's also, at least one of our sites, they do a lot of their work through outdoor activities,
yes.
Land-based activities and so on. So that's the second objective in terms of rapid access. Again, we took it because we had achieved this almost 95 to 100% of the time, is to be assessed within 72 hours. And the assessment is to be done by a trained, and we have provided now training to all the sites, a trained non-physician clinician, doesn't matter what discipline they are. And that's the first point of contact. And when we get to our evaluation protocol, we'll be able to talk about what that assessment consists of. And then after that, connection to appropriate services, a maximum within 30 days. So these are, we believe, achievable objectives. And as I said, once they enter the service, if they need to continue, it's based on need rather than based on age in terms of transition.
Can I ask a question about appropriate services? It seems to me that one of the challenges that we have in Australia, which I'm presuming may be a similar challenge in Canada, is for those remote sites, that the only appropriate service may be the site that they're accessing. There may not be as many community services around in that community to support young people.
It's very true. I think one of the things that we have done is for each site, we trained them to do community mapping. I think what emerged out of that is that often there's a lot more available than people are aware of because the people don't talk to each other.
Yes.
However, you're absolutely right. It's not only in remote communities, even in urban centers. We may have a lot of the sites may have access to an early psychosis service, but don't have good access to an early, youth-focused depression service or services for eating disorders. So that's going to be a challenge, and I think that's the other part that we're trying to work with our partners. So how can we bring that into what this is essentially a frontline, enhanced primary care kind of a setup? How can we increase the capacity, at least even for mild to moderate level of disorders in the access sites? And then, yes, it is going to be a challenge, it's going to vary. And one of the things we hope will happen is out of this, we will be able to identify what are the gaps then. And in some places, we certainly can connect to some services very, very quickly, especially early psychosis, and in some places, addiction services. But you're absolutely right. I think that is a big challenge. In terms of actual service transformation, what we have, I think we're a little bit, this is probably a key element of access, that what we have done is we've taken, in each of these sites, we did for the first almost a year, a very detailed community mapping, what is available, what services are they providing, what's the population they cover. And then the idea is you bring what they already are providing and the resources that are being used, that we add our access resources, which is mostly in the form of access clinician and research and evaluation staff, and in some places peer support services. And you put that together so that the new team is not just what access has provided. It's now the whole team. When we go to do training, the entire team gets trained. And that's not been easy because I don't know about Australia. You know, in Canada, where health services are provincial responsibility, and they have, you know, provincial bureaucracies, and you have one of the biggest challenges has been we go into a site and say, well, these are our child adolescent services, but they stop at 18,
Yeah.
and that budget is separated from the adult budget, and it's taken a
We have
lot.
a similar situation
Yeah,
here, so
I'm
I
sure
can
you do.
appreciate the complexity.
Yeah, you know, part of it was, can we now negotiate that we merge these, even if you cannot merge because they say, well, no, our bureaucracy will not allow us to merge. Well, can we not merge it in actual dollars, but let's merge in terms of the staff.
Yeah.
And some have done it very, very successfully. Edmonton, and again, it's kind of like the person in charge there of the child adolescent part and the person of the adult. They get along extremely well with each other. They work together well. They say, this is no big deal. You know, whether it comes of Chris's budget or Jill's budget, it's the same. And in other places, it's been much more challenging. But the idea is we put these resources together and we build capacity, added capacity, through trained access clinicians as well as training the entire staff. And then we add the all the tools that we're producing in terms of evaluation and that's really the transformation. Some places that has happened actually in primary care, so it's kind of we're enhancing primary care. But other places like Edmonton, that's not possible because they don't have a catchment area kind of concept of primary care. And what has happened there, they already had a mental health service that was being delivered downtown. So we took that entire team, and it's a good example. And they said, oh, we said it'd be good to get off location. So rented a place at the local YMCA, redecorated, and that's become now our Access Open Mind site in Edmonton. In Chatham, Kent, which is a small urban rural area in Ontario, they've done a fantastic job. A local developer, I think, was made to feel that he needs to contribute something, so he let them rent some space. And in the meantime, they put a bid on the gymnasium that the YMCA was evacuating because they were moving somewhere else. So it's a beautiful gym. Access provides funds for each site. It's not a huge fund, but $50,000 to redecorate. They managed to get some extra funds from another donor and government to turn this gymnasium into Access Open Mind site, and it varies, you know, from place to place. But that's the idea, that we transform what is there without actually creating a parallel system.
Yeah,
that's really yeah. Okay. Does that kind of answer the question?
Yeah, absolutely.
I'll just skip that.
Yeah. So perhaps, if you can talk a bit more about the evaluation and evidence.
Right. Yeah, I think the evaluation basically is at two levels, and let me talk a little bit about the governance structure because it is of relevance. It's really when I first started, I said, God, what governance structure?
We just go and do it.
I'm a psychiatrist. I'm a clinical researcher. What do I need a governance? But SPORE insisted that we had to have a governance structure. So our governance structure is basically, we have at the national level, we have an executive committee which has a representation from every site. So we have 13 or 14 people plus. We have a minimum of 2 youth, and we have built this into our terms of reference. We cannot meet unless at least 1 youth is present. So there's no quorum without youth, and there's no quorum if we don't have at least 1 family member. So that's kind of pushes everybody to be involved and to actually make this executive committee very functional. So that meets once a month. The executive committee is chaired by me, and in terms of our internal structure, I am the nominated principal investigator, so kind of basically the buck stops with me, but I have 2 senior people One is we just actually appointed a new director of service and engagement, and this is a person who has extensive experience in mental health services, in youth mental health service, and in management. So her role is to make sure that the service transformation that's happening at the sites is meeting the objectives, and to facilitate and to help them, but also to engage, to make sure that the youth and family are engaged at every step. And then there's another layer of engagement, which is with policymakers, with the government, with the philanthropic foundation. And then we have another director of operations who essentially takes care of all the budgets, human resources, and that. Then the governance structure, the executive council, in a sense, reports to me. I report to an oversight committee, which has 2 members from the Canadian Institute of Health Research and 2 from Graham Beck Foundation, essentially the 2 funders. And we meet every 3 months, but we have informal meetings in between. There are clearly laid out objectives. And then we have a National Advisory Council, and this is an important, they don't have actually any fiduciary responsibilities. But what we have there is about 12 or 13 people from across the country who bring in very different, they have nothing to do with access as such, that they bring experience in advocacy, legal, justice matters, accounting, Indigenous health. And that is a council that I go to. We meet regularly, we meet every 3 months, but in between, when I need some advice, because these are people who have very different expertise that I don't have, and I can pick up the phone and call one of them and say, hey, we have a situation, what do you? And that's very helpful as well. And then we have the Youth Council and the Family Council. Both of these sort of report essentially to me, and through the executive committee. And that's important because everything we do happens through these structures, which makes sure that every site is involved in every activity, including the evaluation. So the evaluation is 2 layers, 2 principal layers, and 2 different methods. The layer 1 is process. What I just described, how we're achieving the transformation, which is, making sure that there's very good community mapping done, all the resources that are there, we're aware of them, they're put together, and evaluating that, if it, how it's happening, whether it's being achieved, evaluating stakeholder engagement. So this is one layer. The other layer of evaluation is obviously both quantitative and qualitative data being collected. And I can maybe show you. Here are, in terms of how we build sort of benchmarks, because we, as we said, that early case identifications and rapid access is kind of at the front end. So for that, the measure would be what percentage of youth that are coming in are being offered service, at least a thorough professional assessment within 72 hours. And in terms of early case identification, we are setting a target that there would be additional cases identified each year, an increase of about 20%. Okay? Because we know that it's untreated prevalence. So we've got to penetrate that untreated prevalence.
And also you can't expect to be accessing everyone in the first year. It's going to take time for that
to build. Going to be, and it's a for most places it's a 4-year project. And then obviously we're going to measure what percentage of people are being connected to appropriate services. And we cannot do this for everybody, but for some sites we are going into a bit more depth, that once they go to appropriate service, are they getting the highest quality possible service? Are they, if they have a psychosis and they're in this age group, are they actually accessing an early psychosis service?
Right, so that's an additional sort of question that you're asking.
And we have the research framework Here it says 12 sites, but we have added a couple of sites since then. So what we have essentially, every site has a minimum evaluation protocol that they have to complete, and I'll show you that in a minute. But out of those 6 sites are in a stepwise randomized, cluster randomized control study, and if we have time, I can talk to you about the challenges of actually doing that in real life. And then out of the 6, the RCT, so-called RCT sites, 4 of them will also engage in economic evaluation, health economic evaluation. But everybody will have the minimum evaluation protocol. And then we have a qualitative strategy that will get into a bit more depth, but only at certain sites. Okay, so that's sort of the overall strategy. And for each objective, we have then measures of how we're going to measure, as I said earlier, for early case identification. In some sites, we are going to go in a bit more depth. For example, we're going to look at pathways to care. And that would be within the RCT, those 6 sites, and we'll be looking at, is there a change both in the complexity of pathways to care as well as actually the time that takes for people to access services.
And I guess just on that, that's something that you've done quite a lot of work in the psychosis space, and looking at how long it takes people to get to appropriate services, and it's an incredibly long period of time. So if we can get people into access and into appropriate care within 30 days, that would be an amazing outcome.
And one of the papers with one of my PhD students, I think it was called something that, where do you have to be to get to where you need to go, something like that, but it's really quite, I mean, sometimes it's scary how many times people see so many people, but nothing actually happens. So in terms of minimum evaluation protocol, it's basically informed by 4 sources. The actual service users, and we are using up until now, we've had to rely on paper pencil because we had some delays in our electronic data capture system. But as of next week, it's going to be up and running. So the service users will enter all of the data into a tablet. And the reason it's actually taken us a longer to build that, I think, is something that we wanted to make sure that when we collect data from service users, from youth, we don't want to just collect data so that we as researchers have the data, but we wanted to make sure that the clinician can have access to it right away. So we have built into the data collection certain red flags. And if the clinician wants a report right away, all they have to do is press a button, they'll get a report on that patient. We won't have access to that because it will have a patient's name and so on. We'll only have the anonymized data. And that, the service providers really, really like that idea, because it gives them, one, that it helps them own the project. They don't see this then just only research. And service users actually like the fact that what they are presenting, that the person who's helping them actually has access to all that information. Then we have the service users complete a distress scale, the Kessler distress scale, and satisfaction, with services, and there might be something else I may have a list there. And then another source of data is the families and carers. Service providers complete things like SOFAs and CGI, global impression. And then we have service level data that's collected anyway in all services that we can have access to at any time. So that's for the minimum evaluation protocol. And the idea of doing it this way, when and if, I hope that it's when, Access Open Minds is scaled up to other communities, and we are actually already beginning to do that. Minimum evaluation protocol will be part of that scaling, because it's actually going to take between 10 to 15 minutes to complete the protocol. So
it's not
yes, exactly. The other thing we have done, and I think if people have this as a challenge, they may want to kind of talk to us about it. Our ethics committee originally, as all ethics clinics, wanted us to have this very long consent form. And like with everything else, we run everything by the youth council, and they said, no, nobody's going to read this, and it was very, I mean, it's kind of scary, 6 or 8 pages. So we worked, it took a year to convince the ethics committee, we need to be creative here and create. So we now have a very short consent form. And some people are using additional aids like visual aids to explain what this is about. And now we're only using actually the short consent form, which is, I think, a page, which I think is, for research purposes, is a good development.
I think it's one of those things that, like you say, people get a 6-page document, and regardless of whether you're 25 or 65, you think to yourself, do I really want to read this? Exactly. I'm just going to say no. Right. So it seems critical to have that consent. Yeah, absolutely.
So in the minimum evaluation protocol, we have, as I said, the clinician rates the SOFAs at the end of the interview and completes the chemical use abuse dependence scale and the clinical global impression. Literally takes 30 seconds, and the Columbia Suicide Severity Rating Scale. So that's the youth complete these self-rated. Ontario Perception of Care tool for mental health and addiction, and this has been developed over many years. And we were looking at it, and then we thought, if there's something already available and it's been tested on Canadian population, it's translated into French, because for us that's a major issue. Everything has to be available in both languages. So we're using that to get the youth's perception of care. They are going to be using a tool to assess at the end of each session their satisfaction with the session. They're going to be completing the distress scale and the self-rated health and self-rated mental. That's very, very brief. Some sites have agreed to use a child and youth resilience measure, but other sites thought it was too long. They don't want to use. And then there is a youth empowerment scale. And again, it's up to the sites if they want to use it, or up to the youth also. So. And again, with the family, it's the same, the Ontario tool for mental health addiction perception of care, and the family empowerment scales. In the economic evaluation, which is going to be in 4 sites, because our healthcare is provincial and the costs are different, so we're not actually going to measure it in terms of unit cost, but for each site we'll have a separate cost measure. And essentially we're going to look at both direct and indirect costs, and it will be calculated both on the basis of healthcare utilization and also quality outcomes, quality of life, psychological distress, and so on.
Which is increasingly important, because we can't just test, or we can't just work out what things cost if they don't work effectively.
Exactly, yeah. And I think one other thing that if clinicians, it might be of particular interest to clinicians, and this was after weeks and months of talking to youth, and they liked this idea, because they all said, we don't like this idea that we go see somebody and get a diagnosis. So at the beginning, all assessments are going to be non-diagnostic. So what we're doing is creating, and we'll test it out, 3 measures: the distress measure, the SOFAS, and the CGI. A composite of that measures will give the clinician an indicator whether this person needs an immediate assessment by a psychiatrist, or needs to be, or can wait and needs to be seen again. So it's a sort of level of severity. And eventually, if the person does get a diagnosis, we'll be able to test out whether this actually is a better predictor of outcome than the diagnosis itself, or whether it actually does lead us on the basis of the severity at the beginning, the severity of diagnosis as well. So, but the youth like the idea that at the beginning, when they go in, they don't want to be told that, look, you have a bipolar disorder. They just want their problems addressed. So that was the whole idea for this. Any?
No, I think you can keep taking us through. I think we're tracking along really well. Thank you.
Okay. I think, as I said, the strength that we have in the project is really family and youth involvement. But at the same time, it's also the most challenging because to keep people engaged when they have other, their own lives to lead, and sometimes family. We have several family members join in at the beginning, very enthusiastic. Then something else happened in their lives. They said, I can't give this much time, and that's why we keep engaging more and more, so that there is a kind of a core group. And I think that's sort of, I mentioned about the advisory council, that's a strength as well.
And like you say, with young people and families, their lives change over time and different things become priorities. But I guess maybe one of the strengths in that is that if families and young people are not able to continue on in a longitudinal fashion, that you're getting the diversity of voices coming through that stakeholder group as well, which I think adds another dimension, doesn't it?
What is interesting is that, let me give a specific example. We have on the East Coast, we have in Nova Scotia an Indigenous site. It's the community. It's the Mi'kmaq Indians. It's about 4,300 people live on the reserve, and this is they are phenomenal people. They have achieved so much through access because they were ready. And I just spent a couple of minutes. This was a community up until 2008 had been devastated by multiple suicides, young people, 15, 16. And like a year and a half ago, I was there, I spent 3 days, they said to me, they said, it was getting so bad, we got so tired of visiting graves all the time. So what they did, they had a change in the leadership. The band elected a new leader who was very energetic, enthusiastic compared to the previous one. And they decided, they called the entire community and said, we're going to get together in a huge arena, and then we're going to walk. So, they but obviously not all 4,500 turned up, but something like 700 people turned up, and they all went for a walk. And in true tradition of their own, started reflecting on what is happening. And what they came up with, the idea is that no one is going to do it for us. We have to do it ourselves. And they have this, I forget the name of the Indigenous leader who basically said, we have to see with two eyes. One eye is the eye of tradition, of their own culture, and the other eye is the Western eye that may have something to offer. So they've basically taken that, and they have done an amazing job. They have huge youth involvement. They have a worker that they already had, whose entire job is to, they have this project called Learn To, and it doesn't matter, learn to swim, learn to play basketball, learn to run, learn to walk, doesn't matter. He just gets people involved, and that's their early case, that's going to be now their early case identification. They have one high school, they have a youth worker placed in the high school, and many of their workers have been service users, or if not service users, they have suffered. Then they also have several elders who have been victims of, I could imagine it happened here as well, of residential schools and trauma and so on. So everybody is involved. In fact, when I went there, they said we're going to have a meeting with various community services, child, youth protection, and so on. I thought, okay, we'll probably have 12 people, 50 people. Everybody turned up. So I realized that this community has really, so they had kind of half of their work is already done. And they are one of the first sites to actually generate data. They are amazing. And they said that, they don't need an access clinician in terms of hiring a new person. They already what they needed was, they said, we don't have anyone who has skills in providing a really good level of psychotherapy, but who also can incorporate this into sort of land-based therapies, more traditional. And that's what they decided to spend their funds on. Okay, and that's the freedom people have as long as the objectives are there. So, that's an example of how mental health cannot be separated from community development.
Oh, absolutely.
And that's why I think large urban centers have a problem, because it's very difficult to pull the community together. And we can see that in Montreal as well, in Edmonton. In Edmonton, they have a hard time getting families involved. But it's no problem for Eskasoni or some of the other smaller sites. They're all involved.
We've been doing a similar project, or a project in one of the Australian states, and similar themes have come up around the regional and rural centres being, in some ways, quite poorly resourced through the state-based systems, but in other ways very creative and very flexible in the way that they approach things. And like you say, when the community is kind of ready to take something like this on, it seems like you can just run with it.
Yeah.
Whereas, I guess, in some ways, traditionally, we've always thought of regional and rural centres as having key, challenges that are very difficult to overcome. But I think, in thinking about the metro areas, that can be a big challenge as well, because your backyard is so big. In a sense that it's hard to know what's out there.
Yeah.
Absolutely. So it's kind of leveraging those strengths, isn't it?
So far we have trained about 130 people. This is as of 2 weeks ago. It's roughly about 10 people at each site on average, which means that not only the workers we fund, but everybody on the team. Most sites have recruited access clinicians. And you'll see here I've said 12 access clinicians, and some are still hiring more, and 2 access liaison workers. This is a little bit different. What we've done in the 2 Inuit sites, because our Inuit sites are very remote, they're small communities, the professionals who work there, like nurses, doctors, they just fly in, provide a service, and even if they stay, they'll stay for 2-3 months. So very early on, what they told us, and this was exactly the words one of the Inuit sites who have to said to us, that we have a lot of white knowledge around, but it doesn't stick, and we need something of our own. So I said, so tell me what would be the biggest need? And one of them said, well, we have sometimes young people who very disturbed, they're very sick. A helicopter comes, picks them up, takes them to hospital, it gets better, then bring them. We have no idea what to do then. Okay. So what we did there was I somewhat hesitantly said to them, I'm just doing a global mental health project in rural parts of Kashmir, which is where I'm from originally, and we're using a lay health worker model. It was funded by Grand Challenges Canada, and it's working very well. Would you be interested in considering, because the whole model is based on you hire people who actually belong to the community, doesn't matter what, they don't have to have any professional training, we train them. And they said that makes perfect sense. So both of those Inuit sites are not going to have professional access clinicians. They are going to have again, they're relatively young liaison workers who we are training now using kind of a modification of the training that we did with lay health workers in Kashmir, and it's based on the WHO mental health lay health worker training. And this actually suits their needs, because they do have access to some professionals, but they don't have access to specialists, and that we're hoping to do through telehealth. So, it's an example of how objectives are still the same, but the actual work is going to be very different for them.
Interesting. And so, in thinking about how these sites have I guess how each site looks, it's seeming to me it's starting to look like they're all quite different and unique in some ways, but in other ways, like you say, the objectives are still the same, the key kind of benchmarks and, aims are still the same.
Yes, I think in some places it's been, everybody buys into that, but especially in a couple of the urban center sites, verbally, this makes sense, but then when you actually come to doing it, like I was saying earlier, you say to them, access is not a project. It is a way for you from now on. We recreate the team, we work together, and then you provide youth mental health service. And what some of them still have this tendency, this is a research project, so we'll keep it on one side, and we'll still keep doing what we've been doing. And then they say, well, we have these waiting lists. And so, well, that's why we're saying, let's put it all together. Let's find ways to reduce those waiting lists by buying in. And that buying in is not easy in some places.
Absolutely. It's not easy in a lot of places, I think. So this is where you're up to at the moment, where you've got to with each of the sites?
Right. We are... I think a couple of the sites we have, these are, kind of bureaucratic obstacles. We have to have an agreement with every site in terms of deliverables, in terms of data sharing, and we have in Canada what are called the OCAP principles, which is the principles that guide any research with Indigenous communities. Some Indigenous communities have, for good reason, taken a long time to really come to terms with the fact that you can still share data, but they own the data. The community owns the data. We only need the anonymized data for the national project. And now we have set up a publication committee, which again has terms of reference where we want to make sure that on one hand we have the objectives of the project met, which is really to produce the evidence, but at the same time that the communities don't feel that we're taking away their data. They actually are going to publish from their own sites with our help if they need it, without actually losing control over it. So that's taken some time. Other than that, I think most of our sites are up and running.
Fantastic. I'm just wondering whether you can talk to a little bit, and I don't know if I'm sort of jumping the gun a little bit, but thinking about some of those process issues in terms of what's been a key driver of the success so far, and what in terms of thinking about if we were to embark on something similar, perhaps not on the same scale, but if we were to be embarking on something similar, I mean, some of the themes that keep coming up are around stakeholder engagement, particularly young people and families, and I'm just looking at, I'm presuming this is from the website, and it looks quite youth-friendly and easy to navigate and those sorts of things. But what do you think have been some of the key drivers of the success so far?
Yeah, I should probably, I'll certainly answer that question, but I think it's probably maybe even more important to look at, looking back, what were the challenges, what would we do differently? I think the key drivers of success are that we got to know each other in the network for about 18 months before we got the grant. I think that was helpful, and that gave us time to build those relationships. At the end of the day, it really does amount to building those relationships. Another strength, which was also a challenge in a way, was the extreme diversity, not only of the sites, but of the people involved, ranging from RCMP, which is our Royal Canadian Mounted Police officers, to lawyers, family members, direct service providers. We also have, I should have mentioned that we have in Montreal, one of the sites it's called Dans la Rue. It's a site for homeless youth. And again, amazing work that they have done in the past, and they just needed this boost. For them, the challenge obviously is if we say, well, we insist there has to be family involved. There's no family a lot of the time. These are kids who have drifted into urban centers. So for something like that, the key to success there was our flexibility and recognizing that what they were doing would not be something you would see in a regular clinical service, because it's a very different role. There's a lot of role diffusion there. They do, they do a lot of music therapies. A lot of the homeless youth bring their dogs in, so they have veterinarian come once a month. They have a lot of physical health issues, sometimes nutritional issues. So it was for us, the strength there was that they had all of these components, and they're also very mobile. So we had to sort of readjust ourselves that, you don't have to have an access site as such. Yours is maybe in a van, in a mobile van, you just keep. So I think that those are some of the strengths. The other strength was that many of us who were sort of leading the project from the very beginning come from the early psychosis field. We had done at a smaller scale something like this, and the model is very, very similar, especially in terms of quick access, early case identification. And the other strength within that is that all of us are service providers. We only have probably two people who are PIs. One is an epidemiologist. Again, she's a psychiatric epidemiologist, very senior, and has very, very good input, but she's not a service provider. And a neuroscientist who's not involved as a neuroscientist. She's involved as someone with loads of experience of research, of ethics, and she is totally, like she said, that I'm tired of looking at rats. I want to get involved with people. And, she brought so much strength and is almost like a thermometer for us. How are we doing? So, but the challenges, I think, are actually bigger than successes, because we are doing something very, very new. One of the challenges, believe it or not, is that CIHR, or Canadian Institute of Health Research, obviously were given this task by the government, but the structure, or at least the content of how CIHR works, is still very medical. Right? So we got, for example, we got this grant, but CIHR has rules what you can spend on. So we said to them, we can't do this project if you follow these rules. You can only fund people for research. You can't fund them to deliver service. I mean, that right away. So we had to rename these people. That was all. They said, no way can you give money to a site for renovation. So one of the things, they would not bend on that. The only way we were able, so we finally kind of got together, and Greenberg Foundation, which is our other half, they said, no, they cannot do this project on this bit. So what we're going to do is we're going to take away 20% of the money because they had basically given the whole money to CIHR. We'll take 20% of it, we'll give it separately. It won't follow the rules of CIHR. So we basically get 20%, roughly almost 20% of money that we can use in a way that we can actually achieve some of these objectives.
And
so that was a challenge.
Objectives as well.
Exactly. we couldn't. I said to them, I said, we might as well just say goodbye. We cannot do this project under these rules. So I think the organizations that are getting involved in this, they need to change also internally. That's the other challenge is that, yes, they had on paper what they call patient engagement, because they're not just mental health, they think of all the other networks, patient engagement. And then when we started Youth Council, said, can you give us some guidance? How do we pay these people? It's been 2.5 years, they still don't have guidelines. So we had to create our own. So these are, they may seem like little, but these are very frustrating things, and they hold you back. The one of, as I mentioned already, one of the challenges is really at some sites, at the site level particularly, getting family and youth involved, not because there are not enough available, that's part of the part, or enough that are applying, but the service providers themselves or their managers are not comfortable. For example, we have set a rule for all sites and for ourselves. When we hire a new staff, the youth have to be part of the interview panel. And one of the sites said, we can't do that. The unions are going to create, trouble. They will not accept this. And we said, well, try it. The unions had nothing to say about it. They actually liked the idea.
Yeah.
And then they came back and said, oh, this was wonderful to have the youth. They'd ask such relevant questions. So I think, I don't know how one would do it differently. Maybe we prepare people better. Another challenge, and it's still a challenge, is that the youth that get involved are usually very articulate young women, university students, although we are getting a bit better at that. But we have a few men involved, but we still do not have enough of young men or women involved who are very vulnerable. I think that is still a challenge. One other challenge is that we are doing this project. 100% of the sites are non-academic sites, and that's how it should be. Otherwise, you're not. These are real service, but they don't have a culture of evaluation. And in fact, this great site we have downtown Montreal, I mean, now they're doing fine. Initially, they said, I don't know, how we can ask a homeless youth who's going to, that you've got to fill these forms. And so we had to really work with them. And now that they're saying, no, they don't mind. They're actually, I think it's the culture doesn't exist, that somehow research is seen as something you're going to burden people, rather than it's seeing that it may actually improve your service. Yeah,
absolutely.
Yeah. So I think those are some of the key challenges. We have one, New Brunswick, the province of New Brunswick, has a plan that they want the entire province to have transformed youth mental health service. The challenge there was to sort of say, yes, I think that's a great idea, but you cannot start there. You have to start at the community level. It took them 2 years to actually get to that point. So they wanted to do, in my opinion, I hope they're not watching, transformation at the boardroom level. Whereas it really has to. Now, finally, we are actually in 3 different communities: a French community, an Acadian community, an English community, and an Indigenous community. And we could have done that 2 years ago. But if you don't actually get to the level where people are actually going to receive services, it's like they were putting the cart before the horse. Because our next challenge right now is really, how do we sustain this and how do we scale it up? And that's not going to be that easy, but that is the ultimate objective.
And what sort of scale are you looking at or hoping for?
Ideally, the 4 initiatives are supposed to create evidence that then would give the entire country sort of a model, then you start applying it. So obviously, I don't think we're going to necessarily be able to do that. However, what it has done already is pretty well every province is talking about youth mental health as a priority. Some are actually investing money in there, and there we look forward to sitting at the table with them. But what would be more effective? For example, in Ontario, we have this Chathamton site that's doing extremely well. They're collecting data, they've done the transformation, the community is involved, so the government has taken notice. Okay? And next door, they have another community about the same size, and they saw what was happening next door. They said, we want to do it too. Okay? but we don't have the funds to give them. But what we did give them is that we can provide you training, you can use all our tools, and they already launched their community mid-February this year. And they're working with their neighboring community because they're working with us because we'll provide them training, we'll provide them evaluation protocol, whatever they need, but we cannot provide them staff.
Right.
And in Alberta, in Edmonton, again, a very successful site. It's a huge, they don't have catchment areas, 1.2 million in the city. So what they're hoping to do is to create satellite access open mines services with investment from the government and hopefully some philanthropic investment as well. So I think we're hoping that the scaling up will happen as we get known locally, that the people hear about, and we're kind of trying to hopefully publicize this. In French, there's a verb, we vulgarize it. I love that verb. So you basically spread it out and let people see for themselves. And this is a good thing. Yeah. One of the things in our project we had said right from the beginning is that if you want to do something similar, send a worker, embed them in one of the access open mine sites for 3 to 6 months. No better way to learn how to do things than to actually be doing it. Absolutely. So that's another method we're looking at. We're offering people to do that. And same with the indigenous sites, even between indigenous sites, like Eskasoni, I said, is doing great. So we are telling other indigenous sites they have done, go and travel over there, spend some time, and see what they have done. Maybe you can actually,
So actually then using the sites to mentor each other. Yeah.
That's happening already quite a bit. Yeah.
Fantastic. Well, I'm aware of the time and we do need to finish up shortly, but I was just wondering whether there were any final thoughts or take-home messages, I guess, for the audience out there and thinking about some of the projects they might be involved in that have similar challenges or similar objectives. Any advice that you might give?
I think the only
it's probably the hardest question, isn't it?
Yeah. I don't have much advice except to say that not to compromise on the fact that we do need to improve quality significantly. We cannot settle for something just a little tinkering. And the second is not to do without evaluation built into it. And we are more than happy to share. I mean, we have spent a lot of time and resources on creating these evaluation protocols. They're relatively simple to apply, and we'd be happy to share them, or any of the processes that we've gone through, which we're writing up right now. And one of the things I have to apologize for, that our website is not as advanced in terms of the content as we would like it to be, but within the next few weeks it will have a lot of the material, as well as material from each site. You can actually go in and see what each site is doing. And again, we're prepared to share whatever we have.
Thank you very much for that generous offer, and thank you very much for being with us today, and we wish you the best of luck. It sounds like a very exciting project, an incredibly complex project.
I know. These are some of my key colleagues, and we have, in terms of investigators, we have about 55 core members. The entire network is about 200 people. Right. We just had a network meeting where we had 147 people attended.
Amazing collaboration and cooperation between all those members.
The other, not advice but suggestion, would be try and get philanthropists involved, sell it to them, because the governments will never be able to keep up with what really is needed.
And I guess that speaks to the level of innovation, doesn't it? Because there aren't the rules to support what you're trying to do.
Exactly. Yeah. If we didn't have this half of the funding, and it's true about all the other networks. Now we have now a network on diabetes, on chronic pain. They all have 50% of the funding is coming from private philanthropy. The only difference is they had to actually find those. We didn't. It was offered to us. So
very lucky.
they're a great foundation to work with, and they're dedicated entirely to youth mental health. Right?
Fantastic. All right, well, thank you very much.
Thank you.
And we'll
It was a
finish up
pleasure.
there. And hopefully we'll be able to post some key readings on the website for people to follow up on.